have nothing to declare. I have recently moved from Derby, UK, following 17 years of work to this hospital in Prague. My lecture is going to focus on timing of surgical procedure, aims of treatment, indications for surgical treatment with special emphasis on burst fractures, and the questions arising from treatment of those. I will have to miss attractive topic of semen augmentation and will reach some conclusions. So timing of surgical procedure, we know from numerous animal studies that the earlier surgery, the better for neurological recovery. And the human study is represented by Michael Felling's study that showed that surgery before 24 hours is much better than surgery after 24 hours regarding neurological recovery. But we know that regardless of neurological injury, the early surgery shortens length of stay, shortens ICU stay, and decreases pulmonary complications. So that's important. On the other hand, we need to really think well, and we should not do surgery on unstable patient, because that could do more harm. Aims of surgical treatment are clear. What is not as clear is to basically put down all the 4 facets of the aims, and that means especially to restore the function of the spinal column, and that means that we should end up with as flexible, as mobile spine as possible. And that's why we need to fight for the very mobile segments extending from T11 to L4 really very hard. And we should as well do early surgery in order to avoid post-traumatic kyphosis. This patient had urgent surgery 4 hours after injury. He had good decompression that eliminated a severe neurological deficit, but unfortunately the surgeon stabilized the whole lumbar spine, and then the patient came to see us a second opinion because he couldn't do any work and he was in terrible low back pain. And as you can see, we have shortened the fixation and regained good range of movement of the lumbar spine. So that is really the goal. The question whether to decompress from the front or from the back has been discussed frequently in the literature. Now a clear conclusion is that there is no difference. Maybe there is some easier decompression from the front, but that is associated with higher blood loss. Indications for surgical treatment: there is clear agreement not to operate on A0 and A1 and some of the A2. There is clear agreement to do surgery on existing or progressive neurological deficit, on major kyphosis, unstable fractures with usually short fixation with monoaxial screws, sometimes with semen augmentation. Clear indication on angst-pon patients with fixing them with long fixation. This is the angst-pon patient. You can see it's a B-type injury, no translation, and long fixation. Similar B-type injury in thoracolumbar spine, which requires a long fixation because it's both columns in, and long fixation provides the stability. In type C fractures, when there is clear translation, we are aiming at short segment fixation. You can see the empty facets there, and short segment fixation with instrumented posterolateral fusion. The main controversy is in type A3 and A4 fractures without neurological deficit. The question is whether we can treat them with braces, whether we should treat them surgically or not, whether we need to perform fusion, whether we can do posterior enough or we need 360, whether open or percutaneous, and there are other questions that we don't have time to discuss. So orthosis, there are a number of studies that show that treatment with orthosis or without gives the same results. Therefore, orthosis treatment is not justified. Surgery or no surgery. two well-known studies, one from the US by Kirkham Wood, comparing 24 surgical and 23 non-surgical patients, to a Ziebenga study from Europe, looking at the outcome of 18 surgical patients and 16 non-surgical. And unfortunately, these two studies came up with completely controversial outcomes. One supporting surgery, one supporting non-operative treatment. So at the moment, we don't have clear guidelines. The AO Spine trauma group is working on a randomized trial. Hopefully the results will be published. The literature we have so far is here, and the conclusion of this is that there was no difference comparing surgical to conservative treatment, supported by 5 out of 7 high level of evidence studies. Surgical treatment provides better kyphotic deformity but showed higher complication rate. And what is really interesting is that 2 systematic reviews pointed out that clinical results are not related to selection of particular approach. So why to do complex 360 surgery when you can do the same result posterior only? And this is what we did and what we are doing till now. This case was treated with 2-level posterolateral fusion. Now, at the moment, we would probably prefer monosegmental fusion and, if possible, monosegmental stabilization. The little loss of correction following removal of the instrumentation has no impact on the clinical result, and the patient returned to heavy manual work few months after removal of instrumentation. Now the question whether we need fusion in short segment fixation in these burst fractures, and the evidence as presented here shows that fusion is not necessary in all cases because it's associated with higher blood loss and pain and infection, but you need to be aware of the fact that all these studies are with small patients. So posterolateral fusion, is this too aggressive treatment now? Well, I don't think so. In some cases, we really need fusion. This is a pure discal ligamentous injury at L2, L3. You can see the extent of the injury of the soft tissues there. And so, in this case, monosegmental instrumented posterolateral fusion is the procedure to select to provide good result. There is trend to short segment fixation, and this is a case for monosegmental fixation. You can see that the spine is reasonably well aligned. This is a tall sports guy, no neurological deficit, but unable to stand or walk. And we were really afraid that he could end up with post-traumatic gradual kyphosis. It was not type A3 as we expected. When we did the posterior approach, there was insufficiency of the posterior column, and so we ended up instrumenting him and fusing him in the back. But in this case, we did not think that posterolateral fusion would be enough, and so anterior column reconstruction was necessary here, and the patient healed nicely. Now, posterior versus anterior versus 360. The literature says that logically there is a minimal or none loss of correction in patients who have 360 procedure, but there is identical clinical and functional result regardless of the instrumentation. So once again, why to do very complex surgery when you can get away with the plain posterior approach? Open and percutaneous. Now MIS is the trend, and it's basically there are arguments that there is less muscle damage, and that is represented by the studies here. Again, high level of evidence. Nevertheless, if we look at the literature, there is still better correction of kyphosis achieved by open surgery, but MIS is a possibility. The question as well is to compare apples and apples, and This is one of our patients who underwent two spinal procedures, one implanting the pedicle screws and one explanting them, and you cannot really see any major scarring in the posterior musculature. So if you are technically well-trained surgeon, so you don't really have to come up with the major damage to the posterior elements. So conclusion of the thoracolumbar fractures. So surgical treatment is clear in type B and C with or without deficit. Timing depends on associated injuries and patient general condition. Keep the spine mobile and not kyphotic. Be aware of the disadvantage of polyaxial screws. Regarding type A3, A4, surgical treatment of patients without deficit is not necessary in many cases, but you need to watch out for post-traumatic kyphosis, and you should do early follow-up X-ray that are in standing position. Surgery from posterior is usually satisfactory. Usually CT scan is very good to assess the healing ability of the anterior column. Spinal fusion is not necessary in many patients. Posterior approach is ideal with short segment fixation. Loss of correction is not associated with worse clinical outcomes. Percutaneous surgery are a trend, but better correction still with open surgery. You need to as well count on the radiation exposure of the team. For your attention.